joining today. My name is Cynthia Klein, and I serve as the Project Director for AHRQ's Take Heart initiative. We hope that you are all safe and well at this time, and really appreciate you continuing to participate in these webinars and join in the discussions that we've been having. We have a really interesting session planned for today that's focused on leveraging your data to enhance your cardiac rehabilitation program. Before we get started, I'd like to make a couple of announcements, a couple of updates related to Take Heart, and they're on the next slide. So based on the readiness assessment that the partner hospitals in the first cohort participated in a little bit earlier this fall, we are looking to restart Take Heart activities as early as April 2021 and kind of pick up where we left off. And when we talk about picking up where we left off, we mean starting with that third training module in the series. As you may remember, we got through the first and the second training module before we needed to pause activities. I will say it sounds a little crazy to think about, talking about restarting with everything we're hearing in the news right now. But some of our thinking is that it does take several months to prepare to restart, and we want to make sure that our hospital participants are as prepared as they can be. We will continue to monitor the situation and will adjust as we need to. And if you are a hospital that really has strong concerns with this timeline, please reach out to us at the Take Heart email address and let us know. We can talk through, some possible alternate situations. In the meantime, you can expect to see a communication from Take Heart for partner hospitals in terms of what activities you can do to restart.
Are you able to hear me? Faintly.
I'm sorry, you guys, I got muted somehow, it looks like. Let me just start off where I was. If you are a hospital that's in our first cohort of partner hospitals, as we look to start in April of 2021, we do have some preparatory activities, and those include a data planning exercise that's very much aligned with today's affinity group, and Steve will be leading us through the discussion. We'll tell you a little bit more about that. We'd also like to ask you to complete a readiness assessment if you are a partner hospital in our second cohort, so that we'll be better prepared to assist you when we do start activities, and we do expect the partner hospital activities for the second cohort to also begin in the beginning of 2021. We will continue to offer affinity groups like these throughout the project period, and hope that you will continue to join in the discussion with us as well. As a reminder, these events are open to anyone, but we do encourage you to join the Take Heart Learning community, and there is the URL listed here. And then I think that is everything. Steve, if I need to go back and repeat something from a little bit earlier, let me know. Otherwise, I will pass it over to you.
All right, thanks very much. And no, I think that is a good overview, and we are all excited about the resumption of the learning cohorts in the spring, and really view today's event as assisting those of you that are working on Take Heart in being ready for when Take Heart resumes in the spring, and really more broadly for helping all of the participants on today's call as you begin or continue your planning for the success of your cardiac rehab program in uncertain times. And Jean, I don't know if there's someone else that's unmuted. Could everyone make sure that their lines are muted? I'm hearing some background noise.
Yeah, I'm trying to figure out who this is. This is David.
All right, but to move ahead about today's event, these affinity groups provide forums for everyone to learn from each other, to share with each other, and to support each other. So this is the 7th or so affinity group that we've had using this format, and we want to encourage you to actively participate using the chat, participating in the polling questions, and engaging with the panelists. We want to explore today's data because data is always important. It's essential for a variety of reasons that Hisham will get into in just a minute, but more generally, in uncertain times, it becomes even more critical to understand your data. So the format today is a moderated panel discussion that will be led, as they all have been, by Dr. Hisham Scali, and we want to welcome him as well as our 2 panelists for today's event, Matt Thomas from the Cardiopulmonary Rehab and Employee Fitness Program at Chi Hospital in Chattanooga, Tennessee, and then Julianne DeAngelis, who's at the Lifespan Cardiovascular Institute, Miriam and Newport Hospitals in Providence, Rhode Island. So it's going to be a great discussion. I'm really excited about it, and let's just touch now on a couple of the logistics for today. If you want to make a comment or ask a question in the chat, you need to set your field to all participants so that the audience and the panelists can see whatever comments or questions you're posing. So pick the all participant option. And if you want to just send a short greeting to the group to try it out, get used to using it, by all means do that. We're also going to be asking some polling questions, and want to just comment about how to do that. The polling questions will come up on the side. You'll be asked questions, and in some cases you'll pick one answer. In a couple of cases you can pick all the answers that apply. And we really use those polling questions to inform the discussion today, and then some of them also give us a good sense and give AHRQ and CDC a good sense of issues, strategic issues that we may want to account for as we plan for the success of Take Heart. So moving ahead, we want to start with the first polling question, a standard question that we've been asking. So what describes or best describes the current status of your hospital's cardiac rehabilitation program? So you can pick one of those answers. Everything is canceled, or there's limited patient visits, or reasonably normal operations but with less than 60% capacity, or 60 to 90% capacity, or pretty much full capacity. So why don't you answer that question, and then we'll just take a look at the audience's responses before we move on to the next question in just a second here. All right, and I don't know if we're going to display the answers here. All right, so reasonably normal operations with 60 to 90% capacity seems to be the most common response. It's excellent to see that you're creeping back towards normal, and I think for all of our sakes and the sakes of our communities, we hope that you're able to sustain that despite some worrisome current trending. All right, as we move to the next question, how would you describe the level of uncertainty about your challenges in 2021? So give us an assessment. Would you say that's very high, high, moderate, low, or very low? And we'll get those responses here in just a second. All right, those should be coming up here shortly, and you'll be able to see whether you're stressing more or less than a majority of your peers in stressful times, and we hope, let's see, moderate. Moderate with probably a few more on the high or very high side than on the low or very low side. So we hope for everyone's sake that things will continue to be manageable. And we'll move on to the third question for today, which is really laying the groundwork for our discussion about data, and we just wanted to get a sense of the EMRs that your facilities may be using. We realize that you might have several, but you can just pick the predominant one, Epic, Cerner, Affinity Health, Meditech, or something that's different from those. So if you can pick an answer there, we'll get a sense for, looks like Epic and Cerner. Not too surprisingly, is about 3/4 of the participants with Meditech or something that's different about the rest of the quarter. All right, excellent. So we want to turn now to the main activities today, and I'm going to turn it over to Dr. Hisham Scali to lead the discussion with our panelists.
Thank you, Steve and Cynthia, for this introduction, and Steve for setting the stage here about the importance of data in our cardiac rehab. I welcome everyone to this 7th affinity group that we're having. It's always exciting, and I always look forward to these, as I tend to learn quite a bit from the engagement of our panelists, but also of our audience. I think we have over 110 people so far. And so today we're going to be talking about how we can grow the value of data in our cardiac rehab programs, how you can figure out what data you might have access to, and what reports you can generate, and how you can use those reports and the data you have to maximize the value of your program. We have two excellent panelists with us that Steve introduced, Matt and Julianne, and they have, I've seen some of the work they do, and it's truly impressive, and I'm very happy that they will be sharing this with all of us. So without further ado, let's talk about the growing, how you can grow the value of your program with data here. And so I think the issue is that like everything else we do in life, there is a action-reaction cycle to it, and we can really act and react based on the data and how we that we get from our different initiatives, and how our environment is changing. We have obviously a lot of financial constraints in our field, and so we need to demonstrate the value and efficiency of our operations. We are all convinced of the clinical benefits of what we do, but we have to convince other people around us that we can do it in a financially sound environment. So I think it is important to understand what the value of the data we have about our patients, about our programs, about our referring physicians, and about the outcome that we get from everything we do. Automatic referrals require accurate and up-to-date data, because that's how you can assess whether that's something that's actually working. And so, and before you can implement that, you need to see where it is you're starting from and see what is the impact of implementing your data. So I saw a comment in the chat box about someone experiencing audio issues. Just quickly in the chat box, you could either say, yes, I have audio issues, or no, I'm hearing you fine. I will keep going, and let me know if there are any issues there. Good. So what I'd like to ask next is another polling question, and this is our question number 4. Which of the following types of patient-level data does your program have that is complete, accurate, and current for potentially eligible cardiac rehab patients? That relates to how we can use automatic referral. The options are there on the right-hand side of your screen from A to F, and you can check all that apply. Do you have access to CPT codes, ICD-10 diagnosis codes, ICD-10 procedure codes, patient demographics. All right, so I think the time has finished and we can see the results. All right, good. So 70% of the people have access to ICD-10 code diagnosis codes, and 50% have access to CPT codes, as well as patient's age, gender, sex, but then less than a quarter or less than a third have access to the other data points. Excellent. So at least 25% for every single one of them. That's good to know. All right. So the other thing here that we have is what data should cardiac rehab program have access to and why. And what we have done here is really split the types of data into patient-level data and aggregated data. And your patient-level data are the data that are specific to each patient in regards to who they are, where they come from, the referral source, and when does the order come from, as well as what is their diagnosis or procedures that they underwent to, and so on. And so this data is also often already recorded in other programs, such as the AECVPL registry, for example, but they can be also directly available in your EHR and EMR based on the detail that's available there. And then the aggregated data is more of a summary or that has more information about your system and about your cardiac rehab program and about the referring physician that you work with. And so it really gives you not only the numerator, so the number of patients that are enrolled in your program, but also the denominator based on how many patients are eligible. And so the percent of patients that are eligible that are enrolled in your program. And then in terms of efficiency of your program, so you can calculate and assess the number of sessions that are available and that are performed by each patient. And then you can see if there are certain trends related to patient demographics, conditions, or referring physicians, or medical conditions that allow you to see if there is a disparity in the patients who are coming to your program, who are able to complete the program, and how it affects their outcomes. And so let me ask Julianne to start here. Julianne is our neighbor in Boston, Massachusetts, and Julianne just down the state from us in Rhode Island in Providence. She's in a very large program, cardiac rehab program there, and I'd like Julianne, welcome to this affinity group. And can you tell us what type of data you have access to, and how do you use that in big strokes here?
Sure. Thanks, Hisham. We use several different platforms that in some ways work together or integrated together, but we use the registry, and that's primarily where we get our clinical outcomes from, so weight change and METs and depression, quality of life, as well as some programmatic information like completion and discontinuation rates and number of sessions completed, demographic information, and we actually upload that into the registry through the telemetry system. So it's integrated into our daily documentation, so we're not doing data entry twice from that perspective. We also use Epic, and we use that to pull reports mostly on access to care, and most of those reports have been developed by our Epic team, and it's based off of information that has been entered in during the scheduling process. So again, it's not duplicated information, it's just reports we can pull from existing data entry points. We also use an Excel spreadsheet to track things that don't fall into those two categories, things we may want to look at in more detail to see if it's impacting the clinical outcomes. So right now we're using a spreadsheet to look at utilization for our ancillary services. So if we refer a patient to the dietitian, do they actually go to the dietitian? That's kind of what we're looking at there. And we use that data, all of this data, in a variety of different ways. With the registry, we had looked at one point, the outcome of the women in our program, and we noticed that they were doing great psychosocially, but not so great with weight and METs. So we took the time and the initiative to develop a women's only class. And now, a year later, we're reassessing those outcomes to see if that class is doing what it was intended to do. We've used Epic to drive changes in enrollment. So we have a report that tells us how many referrals we capture, but more importantly, that report tells us who isn't joining. And then we have created action plans around particular reasoning. So if we're getting a lot of not interested patients, we help the secretaries come up with a script to help them reel that patient in. We've also used it if we've seen adverse spikes in data over time. So if at one point we saw a spike in over a period of a year or so, we saw a spike in patients discontinuing the program in the first couple of weeks due to noncompliance. And we created an ambassador program where we recruited graduates to come in voluntarily and meet with the patients while they're exercising who are in the first 2 weeks. And that wound up reducing our noncompliance discontinuations from 32% to 12%. So those are just, in a nutshell, how we use each platform in a couple of different smaller QI projects.
All right, and Hisham, you may be muted still.
He's still muted. Hisham, I'm gonna unmute you myself. You are unmuted. You keep muting yourself.
All right. Well, while we're sorting that out, why don't we just turn to Matt, and Matt, tell us a bit about the data that you are using and what you've learned along the way as you have really developed some impressive data capabilities at your facility.
Yeah, absolutely. I think based on what you're hearing from what Julie laid out, I'm probably going to be a bit of an echo. In terms of the platforms that we're using, we also use Epic.
Thank you.
We're making a transition to the AACVPR data registry at present, so we don't quite have the leverage that we need with that AACVPR data registry as of yet. So as we continue to move forward, we've been using a lot of Excel spreadsheets so that we can run statistics real time and be able to update it easily. The other thing, and this might be a bit unique to our center compared to what Julie's center is doing, this is one difference, is we pull a lot of information from collaborative registries. So we have a lot of partners in the service line that use other QI initiatives and platforms, one of which probably many of you would have access to would be things like Get With The Guidelines. And we pull those metrics, and in part what we do with that is make sure that the data that we're collecting and we're seeing is consistent across the entire service line. And we try to leverage and work heavily with those collaborations. If we're just seeing a trend in cardiac rehab, we try to make comparisons to maybe further up the chain in the continuum of care and see if there are consistencies, inconsistencies, et cetera. So the platforms are very much the same from what Julie presented. As to how we're using them, I kind of like to make everything a big picture for my team, and a lot of the things and tools that we have put together, I would say, have just really come to life out of wanting to be able to show data to the team so that they know what they're doing is working, as well as higher ups. Again, I think Stephen pointed out, or maybe it was Hisham, that we know the value of our work, but if we can't show that, it's kind of difficult to make that case. So putting the data together, I kind of look at things from the standpoint of scheduling, staffing, marketing initiatives. Are our referral systems working, and are they doing so completely? And then looking at it, as you're seeing on the screen now, kind of that patient level data. And I really like this slide because it puts the patient level versus the aggregate data into really two nice columns. But those are really kind of the big overreaching areas that we use for our platforms.
Hello.
Hisham, welcome back. Sorry for the delay. Go ahead.
So sorry, my platform froze completely, and I had to log off and come back. From what I heard, Matt, you guys continued to do this without me, so that makes me feel good, actually, that you can go on without me. So, excellent. So, Matt, I assume I lost you there for a few minutes. I assume you described how you program was using some of this data and the importance of using the data.
Yeah, that was right kind of where we were wrapping up what platforms we use, and I kind of gave some umbrella terms for, or kind of umbrella categories rather, on how we're using the data, but no specifics as of yet.
And just as a preview here, Matt, can you tell us, what big change that you, or small change that you made based on the data that you've been collecting? Any kind of adjustments that you made?
Yeah, absolutely. I'd say probably the biggest we've made in the last year has been what we're doing with kind of our throughput. I think I even have a slide that speaks to this. It wouldn't be premature to move to it now if we can. But, when we look at our program, and these graphics certainly aren't exhaustive. I know that these aren't the complete battery of diagnoses that we see in our clinics, but one thing that we did early on was we looked at how long it was taking patients to start our programs and who the patient demographics were. So we really took the data and got a picture of who our average patient profile was. And that allowed us to do two things. One, we knew who we were serving and who we were serving well, but most importantly, we were able to better understand who was being underserved in our facilities. And I'll get into a little bit more of that later, but another initiative that we took on using the data that we had was we had an average time of about 21 days for patients to start our program. So that would be from their discharge from the hospital to when they began or had their first interview. That was August of last year. We set some initiatives, followed the data, and we now have that down to about 10 days on average. And it was just identifying that our time to start was that long. And really just tracking those outcomes that we were able to improve it. So, you think about the downstream effects that can have if you go down from bringing a patient in on average from 3 weeks to less than 2 weeks. That does a lot for your throughput. You're able to see more patients, and it has a really, really broad stroke over your entire operations.
Yeah, definitely. And there is also data that supports that the sooner you see patients, the more likely they will actually complete their participation and graduate with a higher number of sessions. And so, and more likely, the sooner you see them, the higher the likelihood that they will actually participate at the beginning. So very important to be able to collect that data, notice that, and then intervene on that. So as you said, there is a positive outcome on multiple parameters. That supports this notion of, yes, we need to get that data. So next, let's see our next audience polling question, but what types of reports do you receive or can you generate on a regular basis? Give us a lay of the land about where we're starting with our audience here. So let's start the poll. So a few more seconds to go here. Good. So we have our answers here. So the first two questions are about, the first two options are about patient level reports, and the last two are about aggregate reports. And so it's really a matter of whether we're getting all the data that you need or just a portion of that, and for each type of report. And you can see that about a third to 40% of the participants are able to get, or actually 60-70% are able to get some portion of the patient level reports, but barely 50% are able to get aggregate reports. So it tells us that there is room for us as a field to understand the importance of getting data, and that how we can get the data that's needed. And I think that's the next question about, the data is out there. The important thing there is to understand why are we getting it and what we're going to do with it. So we should have a clear question, a clear objective of why we're collecting the data, how we're going to present it, and what we're going to do with it. And I think that's a key concept to understand when we do this kind of initiatives. And as Matt and Julian said, it usually helps not only the patients, but also the enterprise and also society as a whole, when we're able to know the disparities that we have and how we can reduce those disparities. So it does improve every single stakeholder that's involved with this. Julian, could you please give us some examples? I mean, and that's what you started by telling us, when you're using different data registries, like whether it's AHCVPR or the reports you get from Epic or in your Excel spreadsheets, how you were able to tackle different angles and perspectives with this approach. And maybe your next slide can help with this.
Sure. So this is an AHCVPR registry report, and if you're already using it, you're probably very familiar with it. So this is the report that looks at what your program's aggregate outcomes look like compared to, in this particular instance, I did similar size programs over a 6-month period between October of 2019 to March of 2020. So the first page gives you more of that demographic and programmatic information in terms of diagnosis breakdown and age and gender, comorbidities, and then the second page gives you more of a clinical idea. So if you look at this particular report, if you see under where it says CABs for the bypass, on the first page left column, we have kind of less patients we're seeing that are bypass patients versus we have more PCI patients. That tracks with our health system. However, if I was in another program, I might be saying to myself, why is that? Why is it lacking behind? So am I missing those referrals? Are they just not joining? So it's an opportunity to say, what do I look like against other programs to see where maybe you have a gap or an opportunity to improve. So it's important, I think, number one, to compare against yourself. So it depends on where you're starting from. If you haven't been doing too much on the outcome side of things and the data collection side, you may just want to benchmark against yourself quarter to quarter, year to year. But then the next step after that would be to look more at what you're doing against another benchmark, whether it's what Matt mentioned earlier or something like the registry. On the second page, you can see that we track pretty well in comparison to in most categories, to most of the groups, to most of each field. The one place we look like there's a gap is in the 6-minute walk test, where the comparison group is showing a 300-foot improvement and we're only showing a 30-foot improvement. So to me, that would mean I would want to go back and look at what a little bit larger group, more than 6 months, and see if that tracks. And if it does track, that's an opportunity to make an improvement either at the patient level with the exercise prescription or maybe at a process level somewhere. But that's how we use these reports. We look at it and we say, where are we differing from a comparison group? If you go to the next slide, I can talk a little bit about this report. So this is our Excel spreadsheet that's more of a homegrown thing, and it is tracking, looking at the utilization of the dietitian and the psychologist in relation to patients' weight loss goals or dietary goals, and then also our usage of our behavioral psychologist or our tobacco counselor in our smokers. And this is something that has evolved over time. It was a much broader look at utilization, and over the years we've realized that this is where our opportunity to improve our program lies, so we've narrowed it down. So the staff, as patients graduate, they just quickly enter these yeses and nos into this spreadsheet. It takes about 30 seconds per patient, and then we're able to look at that. And we actually had a physician who did a paper on looking at if a patient set a weight loss goal, did it track to losing more weight? And it seems like a no-brainer that answer is yes, but she was able to show statistical significance to that question. You can go to the next slide. And this is a patient-level report. So we had our behavioral medicine research department put together this access database that has all of our entry and exit discharge assessments in it, and the patients sit right at the computer in the portal and do all their assessments at the computer in about 15 minutes when they come in for their intake and before they graduate. And so this report allows us to direct the patient care. So you can see on this particular report, under PHQ depression, that's mildly elevated. Under the rate your plate is a medium level where there's some improvement needed. And then at the bottom, the Mariski medication, that's an adherence, medication adherence questionnaire, that's pretty elevated. So what that means is we then can direct the patient that, okay, in addition to your general cardiac rehab education, they need an appointment with the pharmacist, the dietitian, and the psychologist. So that, in the end, over time, will improve our outcomes, and it also circles back to that utilization spreadsheet. So those are the three main things we use in terms of clinical style reporting.
Thank you, Julianne, and that's pretty exhaustive, actually, and very interesting, as you said, showing like 3 different levels of how you can use your data and reports, whether it be at the patient level or at the aggregate level, comparing yourself over time or comparing yourself to other programs, and having initiatives such as the weight loss initiative that you had, and you aggregate that into a progress form, and as you said, you had a paper coming out of that, the program had a paper coming out of that. And then also directly at the individual level, when you showed that with this last example of using this data and being able to tailor your intervention to a patient, to data, to metrics that are relevant to them directly. Excellent. So let's get another perspective from Matt in terms of what reports you're able to generate and the queries that you're able to get.
Yeah, absolutely. So these are by no means exhaustive for some of the data that we look at in different parameters of our program, but I did want to bring some of these forward because I think that they present some unique opportunities for program. And these would really be taking things on from more of an approach of operations. So if you look at the top left, this is a graph that we generate, and this is populated. I usually go by this one we update about once in a biweekly period, so every 2 weeks. And what we have is referral percent strictly by provider. So this is kind of interesting because it tells us who our main referral sources are from our group here at the hospital, or part of our organization. I also had another report that shows who our main referral sources are from outside sources. So from this, you could do a lot of things. It's not necessarily something you should use to change your doctors into giving you more referrals, because it may be based strictly on their schedule and number, how many procedures that they do. Your biggest referrer may be doing your most procedures, and that's just could be the setup of the clinic and the practice. But what it does do is help you highlight where your referrals are coming from, and maybe you will find some opportunities to talk to your doctors so that they know kind of where they are, if they're hitting the mark, or if there are opportunities that you can explore with them. So I guess the recap for that is take it for what it is. Make sure you look at the other pieces before you approach your docs, but it can give you some good insight on where your patients are coming from and for what. So if we move to the top right, so another thing that we track is, and the ACVPR registry does this as well, but I like to put it into a graphic means so I can show it to the team. This is program participation by zip code in our area. And these are for our major sources. And basically what you're seeing here is pretty clear cut. We have some zip codes that are low participation percentages and some that are high. Now, where we are in Chattanooga, there is unique geography. We are surrounded on a couple sides by mountains. We do have some of these zip codes that are on top of the mountain, and so weather, time of year, how far people are willing to drive, as the crow flies, they may be pretty close to our centers, but you take mountainous wandering roads and that can be a limitation. So what we've done with this data is use it again with that collaborative approach, and I took this graph to our marketing team and let them do what they do with it. Can we see opportunities, maybe socioeconomic opportunities within the zip codes in the city that we could be able to target and market our programs better? Can we talk to our doctors and have them help us leverage to some of our underserved patients that might be in these specific communities and finding advantages for growth there? This one will be big for us if we can get the bill passed in the House that we've been fighting for, the ACVPR Day on the Hill, for several years. We'd be able to strategize maybe where other programs should be developed in our region. Bottom left, average discharge time to interview. So this is that metric I talked about, and this is just a snapshot of that so that we're able to see strictly, all right, how many days is it taking for patients to discharge? And this can be diagnosis specific. Also, as I kind of mentioned in the chat, I do have some correction factors put in for the diagnoses to account for, your cardiothoracic patients that have a delay to start. But that shows that, again, this is operation specific. So you're able to make real-time decisions on what kind of staffing you need, how often people are coming through the program, some of the length of stay data. It's putting all these pieces together to look at the big picture of your operation. And then this last one, I know a lot of finance departments should be providing these reports because most of us live or die by productivity, right? But we run some of our own reports as well, and this helps me staff, especially in a time where our volumes have been pretty drastically impacted. We're all dealing with that during this public health emergency. This is a workbook that I have that strictly puts the number of raw visits that we have from our patients, and that's on the left, against the number of hours that we're working per pay period. So long as that volume graph is above our working hours, we're in good shape, on we go. If we start to see some trends, then we might need to be making some adjustments in the hours that we're working, our staffing, or taking a look to see why the volumes are suffering. Again, looking at the big picture, the big trend. And if, Hisham, you could move to the next slide. Kind of on that same front, this is a workbook that I made during the first week of the pandemic. So our phase 3 program before the pandemic had run at about, we were just over 600 participants in our phase 3 program. Within days of the pandemic, weeks, we cut that volume in more than half. So the staffing model that we had was no longer going to work. So we had to cut out hours. If you kind of look at one of these blocks, you see I have it set up Monday through Friday, 6 a.m. to 5 p.m. We cut out class times. And what I strictly did, we set a metric of how many people could be in our gym at a time. And I just went on percentage of capacity for each one of those blocks. And just as a quick visual, Excel did all this for me, made it pretty and colorful, gave me the percentages, and then as the weeks went by, I was able to see if we were trending up as people were starting to come back, and or as what we're seeing in the last few weeks, we're starting to see folks are feeling less comfortable to come as we're seeing spikes, particularly in our area and across the nation. So day to day, this isn't that helpful, but I've been doing it for 20 weeks, and we're really able to staff much more intelligently, especially now that that's really being scrutinized.
Excellent. That's actually quite impressive as well. And again, this joins another theme that I've picked up on between what you were saying and Julianne were saying, is that this data and these reports don't come up overnight, right? So it takes time to actually build up the collection of the data and also get up these trends and then get your intervention and then assess your response to your intervention and so on. So we need to be patient and be thoughtful about how we build our data collection forms and what we're going to do with it and until we see results. Sometimes we can go backward and retrospectively collect this data and these reports, but often we do it prospectively, and it takes time, but that's the name of the game, and it comes with patience, and I'm sure in our field we've learned a lot of that. So I think it's impressive that you showed all these numbers, and again, strengthen the fact that how long it might take. So, and that helps us in this next stage about how we can really maximize the value of data and reports that we have access to. So, I might start with Julianne here. So, Julianne, how long have you been using the AACVPR registry, your program? How long have you been using that?
In about 6 years we've been, so mid 2014 is when we started using it.
Nice.
But prior to that, it was just a basic Excel spreadsheet.
Yeah.
We weren't looking at quite as many things, but we were, looking at our data, and we just did it all by hand in an Excel spreadsheet, both from the stuff we get out of Epic,
yeah,
as well as the stuff we get out of the registry currently.
Okay. Right. And so how did that help you set up priorities, and what kind of progress have you been able to assess over time?
Yeah, that's where we start to look at trends within our own department. So looking at things quarter to quarter, looking at things year to year. If something starts to not look like it always did, we may take a step back and try to figure out, what's different. So, for example, for many years we tracked falls as part of the hospital's National Patient Safety Goal QI projects. And
yep.
In 2012, we saw this. We've got new treadmills, and we had this huge spike in falls. So we had to regroup and look at and analyze why those falls were happening, and it was revolved around the complexity of the new treadmills and space, because they were a little bit bigger than the ones we had prior to that. We put an action plan into place, trained the staff, focused on teach back and those kinds of things, created a little more space on and off the exercise floor and so on. And that resulted in the next 4 years, the falls steadily decreasing and getting to lower than they were before we started. But because we continued to look at it, we saw another spike in 2017 and realized that was related to a large influx of new staff who never got that training to the intensity that the old staff had. So we kind of buckled down and retrained and reinforced, and were able to catch it quickly so that it didn't get any further out of hand. So that's how, things that you're tracking, when you're looking at your own trends, you can make changes and adjust on a little bit more quicker basis. You think quicker on your feet when you have the data right there to show you what's going on.
Excellent. Well, there you go. That's another real-life example of you have action and reaction and being able to identify what was the cause of the problem, fix it, and then see that the problem happened again, and then find a different or slightly different perspective there. So kudos to you for noticing that and sharing that experience with us. Matt, how about you? Anything on the marketing perspective, on the marketing department?
Yeah, so as I pointed out a moment ago, we shared that zip code data, and actually our marketing team came back and they were just thrilled that we had that information. And one thing they expressed is they wish that they had a bit more of that targeting for other programs, specifically for outpatient programs. So they went with it, and we I'm sure that they took on some marketing strategies on their end. I know that they did. I haven't necessarily been into those communities to see those efforts, but, we made some changes as well. As you, Hisham, kind of alluded to in some of that extant literature, we know that the quicker we can reach and engage with patients after discharge, the more likely they are to participate. So, literature says about every day that they're out of the program before they start, that's 1% decrease in their likelihood to participate. So we decided to take advantage of that, and in real time, as we screen where these folks are from, we have a conversation in our phase 1 programs, and we make sure that we have follow-up within 3 days. Now, that may not be an interview, that may not be a visit, but it is at the very least a phone call so that we can engage and work to bridge the gap of care until those patients are able to get into our centers and participate. And a lot of that came out of that data that we shared with that marketing strategy.
Excellent. Yeah, so there you go again, another real-life example of changing things based on the data that you have. So, as I said earlier, these things take time. You gotta be very patient. You gotta be thoughtful. So what kind of advice and suggestions you might have for other programs and participants that might not be as far along in their process of getting, using, and implementing this data collection and reporting? Matt, what would you suggest?
Well, I think the big thing is to start small and not to be intimidated. I have several reports that I run, and I'll be really honest with you, I've put a lot of work into building Excel spreadsheets. You kind of have to pay to play. But start small and get a picture of who your populations are. I would say, especially for our rural peers, if anyone really is out there and you do not know the average demographic or the patient profile of folks in your center, then you're underutilizing your data. You should at least know who you're serving mainly. And that is really pretty easy to find, and it will change how you operate. It really has a lot of potential. So even some small strokes can have big impact.
Excellent. Yeah, so I think that's what you said. Starting small is extremely important. In the beginning, you might start just by, as you said, learning and describing your population and your program and your referring physician and your referring hospital and the cases you get. So just getting that snapshot could be extremely important before you decide to do any kind of intervention, any kind of reporting. Julianne, any advice or suggestions for programs who are starting or not as far along as with your experience?
Yeah, I agree. Start basic. Start with the basics of data collection, what's important to you right now. But I also think it's important to engage staff. Sometimes we get overwhelmed with this because we think it falls on the supervisors and the managers, but if you engage the staff in it as well, that's a huge thing. I had 2 staff today just say to me, well, if I want to change how I do this, what data should I look at? What data should I be collecting? So they're collecting it in their own little way to see if what they want to pilot is working. And leverage whoever you can, whether it's your EPIC team or your Cerner team, whoever is responsible for doing reports from those particular things. Let them know. Our office manager is always like, well, my manager wants A, B, and C. Can we pull that information? In any other department you might have. We have a behavioral medicine department who does a lot of research, so they're always willing and able to help us pull data and look at it. So anywhere you can collaborate, anywhere you can leverage, other people's skill sets, engage your staff, utilize interns. A lot of times I'll hand interns a stack of papers and say, hey, can you put this in this spreadsheet or pull this data for me? They're a wonderful asset, and it's a learning experience for them as well.
Excellent. Thank you. I think I really like that, Julianne. I think the involving the staff both in the concept of what data you're going to be using and then in the data collection is a very important step. Your data is only going to be as good as how you collect it and the person collecting it and use it and actually put in it. And so that's why the involvement and the engagement of the staff is extremely important. And then the collaboration with other programs and other divisions and other stakeholders, whether it be the programmers at EPIC or Cerner or other divisions, is extremely important. That's how you can get as much help as possible. We're nearing the end of the hour. Let's see the chat box if there are any questions here that, or if you do, you could write them there. About how we use this or why you're writing your questions. I'm going to pass the baton back to Steve about what is our next resource here. Thank you again, Matt Thomas from Chattanooga, Tennessee, and Julianne DeAngelis from Providence, Rhode Island. I really enjoyed this discussion here, and it is really very heartwarming and impressive what you've been able to do with this data collection and reporting.
All right, thanks very much, Hisham. And if today you got excited about the kinds of things that your peers are doing with data, and you're sensing that maybe you could do a bit more, but you're not really quite sure how to begin, we wanted to make a resource available to you. And it just gives you a chance to kind of think through and sort of do an inventory of what data you have and what reports you have, and then to think through what sorts of steps you might want to take to address some of the weaknesses or gaps that you see in that. So this is a resource that we've developed. We've gotten some feedback from some of your peers that have used it already. It's something that we really like all of the cohort 1 participants to do. But on the other hand, anyone that's on this call may find it a useful thing as you recognize that, maybe we could do a bit more with the data. This can help you through the process. So it's just a guided process where you can kind of ask you questions. What data do you have? What reports do you have? And then what are you doing about it? And then, ask you some questions about, so if you want to adjust some things, what could you do in response? So we will send that out to everyone on the call today in the form of an email. Ultimately, it'll be online, but just to get it to you quickly, we'll send it right away by email. We'd like the first cohort hospitals to try to get that done by December 18th and send it back to us. If you can't answer everything, that's okay, but it will just help you along, because if you don't have data, you really aren't ready to do automatic referral yet. So just to mention as we close, the AACVPR registry was mentioned multiple times. We know that ACC has a registry also that some of you may also be using. There's information for that available online, and we said that we would circulate the report by email, or the planning guide by email. As far as our next group, we want to talk about your strategic planning for 2021, particularly in light of the CMS final rule, which should come out sometime in November. So we have that call scheduled for noon on December 10th. And then we want to continue discussing topics with your peers. There are some chat questions that we weren't able to address today, and we'll try to follow up on those and give you some updates on that. We'll certainly circulate the slides from today as well. So as you close, please answer the short set of feedback questions so that we can see what worked well and where we can improve. A few logistical bobbles at the start today, but we appreciate you hanging in there through those. It's just a part of the world in which we live these days. So thank you very much. Thanks again to our panelists and to Hisham for moderating the event. And we look forward to talking to you again in a week, or in a month on our next affinity group. Have an excellent afternoon.